Bismillah ar-Rahman ar-Rahim. Good evening. It gives me a great pleasure to be here this evening with you in this beautiful and great meeting. I would like to speak today about something different than the optical world, but it related to the visual health. I would like to speak about how do we deal with glaucoma suspect? When I should treat glaucoma suspect? As a reminder, glaucoma is very dangerous disease. He is responsible or is the first cause of irreversible blindness in the world. So it's very dangerous. First, what is suspect? Suspect is obvious, but not so obvious. We need to complete the puzzle. For the glaucoma suspect, those patients who have elevated intraocular pressure, but no clinical signs of disease, or alternatively, whose pressure are within the range, but who show other signs of concern. As a reminder, for many years, the diagnosis of glaucoma was based on three factors. First, elevation in the intraocular pressure and defect in the optic disc and visual field. As you see here in the first photo, there is a hemorrhage in the rim of the optic disc, and in the second photo there is enlargement of the cup of the disc with glaucomatis suspicious in their appearance. That's the question now revolving around the treatment of glaucoma suspect. Let us take a look about the epidemiology of the ocular hypertension. It's individuals with IOPs of 21 mm mercury or greater with the normal visual field, normal optic disc, and open angle, and absence of any ocular or systemic disorders contributing to the elevated IOP. Some clinicians prefer other names for this group, including glaucoma suspect, open angle glaucoma without damage, and early glaucoma. The concept of ocular hypertension is important. Why? Because it occurs in 4 to 10% of the population over age 40 and up to 18% of Black African. So the ocular hypertension is clearly far more prevalent than primary open-angle glaucoma. The ocular hypertension treatment study, OHTS, found that at the end of 5 years, 9.5% of observation group developed a glaucoma endpoint, whereas only 4.4% of treated group did. This creates dilemma about what to do with this individual who at increased risk for developing primary open-angle glaucoma. On the one hand, the ophthalmologist wants to intervene as early as possible to prevent optic nerve cupping and visual field loss. On the other hand, most ocular hypertension individuals will complete their lives without developing suspicious visual loss. The question now, if it is not broken, don't fix it, or do you? You must ensure that a disease actually exists and that the glaucomatis process have begun. Glaucoma isn't like cancer. What are you really preventing? You aren't preventing anything. So it's okay to wait. But what kind of waiting? Watchful waiting, a reasonable approaching. We should do all the evaluation of the measurements of the central corneal thickness, its influenced the IOP, and do estimating for the optic nerve and nerve fiber layer with imaging devices like HRT, OCT, also a perimetry, white on white, or perhaps blue on yellow. Doppler OCT maybe help us understand the role of perfusion in the caution and treatment of glaucoma. After a full evaluation including measuring central corneal thickness, observing the optic nerve and nerve fiber layer, and recording these structures with an imaging devices such as HRT or GDX or OCT, and after testing visual field with white on white perimetry and perhaps blue on yellow, you are stuck. Whom are we going to treat? Maybe sometimes we use risk calculator, but it's not always available. So we want to know who want to treat. Treatment should be instituted if early damage is detected, the patient appears to be at a high risk of developing primary open-angle glaucoma. Many clinicians institute medical treatment if the IOP is 30 or greater, noting that the prevalence of glaucoma at this pressure level is 11 to 29%. Other possible indication for treatment: a one-eyed patient, young patient, and reliable visual fields or optic disc assessment, a patient who is with the treatment by another physician and who is tolerating the medication well, an ocular hypertensive patient who desires treatment. When to treat? The patient should be a participant. You should engage your patient in decision-making process. And don't forget to follow very important guidelines. The guidelines for following up is necessary to determine whether there is change in the IOP, optic nerve head, or visual field status. Follow-up of glaucoma suspect should be at least every 6 to 12 months. Visual field should be observed every 6 to 18 months and compare with the baseline. Gonioscopy in suspicious of angle closer. Should a glaucoma suspect be treated differently than patient who has the disease? No. Always we begin with medical treatment, eye drops. And we suggested promethazine because for his neuroprotection advantage. And it's good chance to me to refer about two new glaucoma medications, targets the trabecular meshwork disease tissue. Vesolta and Reprosa may play a role on blood flow to optic nerve and promoting survival of the retinal ganglion cells. Also, cyclo G6 glaucoma system for non-incisional treatment. It's a good option for the earlier disease in which we want to avoid filtering blip or placement of hardware in the eye. The micropulse energy induces construction and expansion of ciliary muscles bundles that results in the aqueous outflow pathway reorganization and give us over 30% IOP lowering. So to conclude, more challenging scenario in which a patient is diagnosed suspect. That means probably their pressure was high or their nerve fiber or optic nerve looked suspicious. After a full evaluation, we have gotten to end of the process and made the determination that this does not yet meet the threshold of glaucoma. Does the rate of perimetric loss, for example, diminish if treated early? Does the disease progress more rapidly if therapy is begun after perimetric damage occurs? Investigators will be watching to see if those who convert to glaucoma will progress at a faster rate than those who were on medications from the start. That's what most of us are interested in. What is the threshold of risk? Future answers to today's questions. Let us take a look at famous eyes. Whose eyes are they? Do you know him? He is very famous in 15th. Richard Robinson. He is an American singer. He often referred to him as a genius. Unfortunately, he blinded during childhood due to glaucoma. I can't stop loving you. They say love is blind. It must have glaucoma. I can't stop loving you. I think it's an amazing song for tomorrow, Valentine's Day. Thank you for having me. With all love from Damascus.